Symposium 10, dedicated to critical care medicine, with discussions on ARDS, current evidence and future directions, acute kidney injury, and clearing the roadblocks. It's my pleasure to invite our chairpersons, Dr. Lilanthi Subasinghe and Dr. Waruni Samaranayake. I would now invite our chairpersons to introduce the speakers and panelists for the session.
Thank you, Niranjan. So, our first speaker of the symposium today is Professor Eddy Fan. Professor Fan is a professor in the Interdepartmental Division of Critical Care Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto and a staff intensivist at the University Health Network's Sinai Health System. He's currently the medical director of the Extracorporeal Life Support Program at the Toronto General Hospital. Dr. Fan's research is focused on advanced life support for acute respiratory failure and patient outcomes from critical illness. He has published over 400 peer-reviewed articles, given over 300 invited talks, and currently holds research funding from provincial, federal, and industry sources. He's been named the Clarivet Web of Science highly cited researcher since 2022, representing researchers which rank in the top 1% of citations for their field over the past decade. The topic he has chosen for us today is ARDS, current evidence and future directions. Over to you, Professor.
Great. Well, thank you very much for the kind invitation to speak, and it's been a fantastic time here visiting Sri Lanka for the first time. So I'm going to talk today about ARDS, current evidence and future directions. Here are my disclosures, and I'm going to be speaking about any specific devices or products in my talk today. Okay, so what is the problem? So we're here today to talk about ARDS, and ARDS is, in my mind, a very important problem for ICU physicians and internists who manage patients because it's a syndrome that's caused by many common problems, okay? And the important thing when thinking about ARDS, like many things in critical care, is that this is a syndrome and not a disease, right? So ARDS doesn't exist in nature, we made this thing up, right? And every few years we get together and come up with a new refinement of the definition, much like sepsis and these other things. And so the most current iteration of the definition of ARDS, or the acute respiratory distress syndrome, is the Berlin definition. It's the definition we came up with over 10 years ago in Berlin, which is why the name is what it is. And this was more of an evolutionary than a revolutionary change in the definition of ARDS from the former 1994 American-European Consensus Conference definition, and really just meant to refine the criteria that we have for the syndrome that we realized were a bit deficient in the 17 years that the AECC definition was used. So we could see here are those criteria that, as the name suggests, is acute. So it's an onset within a week of known new or worsening respiratory symptoms. There needs to be evidence of non-cardiogenic pulmonary edema on a frontal chest X-ray, which is the hallmark of the pathobiology of ARDS. The edema, again, it's non-cardiogenic, so you need to rule out heart failure or hydrostatic edema as the primary cause of hypoxemia in these patients, although in some patients they can coexist. And the biggest change in this definition from the former definition, which used to have the moniker acute lung injury, or ALI, which was very confusing, we created 3 mutually exclusive categories of severity based on hypoxemia. So you now have mild, moderate, or severe ARDS depending on how severe the hypoxemia is. And we measure hypoxemia using the PaO2 to FiO2 or PF ratio. So you have some understanding of how much FiO2 you have to give to get a certain PaO2 in the blood. And so if the PF ratio is 300 to 200, you have mild ARDS, 200 to 100, you have moderate, and less than 100, you have severe. And when we came up with the definition, what you could see is that it's a pretty normal sort of shape distribution. About a quarter of patients have mild, a quarter have severe, and 50%, or the largest proportion, have moderate. And importantly, as the severity increases, the mortality increases, so that in mild patients, you have a mortality of about 25%, but it reaches nearly 50% in those with severe ARDS. And as I mentioned, this is a global problem. So after the Berlin definition, we undertook a global study called LungSafe, sponsored by the European Society of Intensive Care Medicine, to look at the prevalence of ARDS amongst ICUs around the world. And what we found was that up to 10% of ICU patients had ARDS. That represented about a quarter of all mechanically ventilated patients in the world. And in the 50 countries that we looked at this epidemiological information, if you use data from the World Health Organization and the World Bank to scale up, that's more than 3 million patients a year getting ventilated for ARDS. So truly a global problem. And of course, the reason that it's a major problem is that mortality remains high. So in the 50 or so years that we've had ARDS as a syndrome in critical care, mortality for all comers has been about 40%. And when we looked at mortality around the world in the LungSafe study, we see that nothing really has changed. So in 5 decades, despite billions of dollars spent on research, trying to understand the disease, look at new strategies for treatment and management, mortality has been the same. And for all comers, it remains 40%. So we need new tools, new methods, new treatments to really figure out how we're going to solve the problem of the unaccessibly high mortality that continues in ARDS. And of course, it's not just mortality, right? We now know that amongst those who do survive, they go on to have long-lasting morbidity, right? Something we now call post-intensive care syndrome. They don't go back to work. They're weak. They have anxiety, depression, post-traumatic stress disorder. There's a huge caregiver burden amongst survivors. There's lots of problems that happen even if you manage to survive ARDS. Again, things that we need to figure out better and understand and treat for those people who move on from ARDS. And maybe the biggest discovery in the last 50 years of ARDS is that as much as we don't have a silver bullet for ARDS, and we don't have one for sepsis and all these other syndromes that we have in the ICU, but we use mechanical ventilation as a support strategy, right? So it's important to remember that mechanical ventilation isn't a treatment for ARDS, but we give mechanical ventilation to maintain gas exchange, right? To give oxygen, remove carbon dioxide, while we're treating the underlying cause, right? We're treating the pneumonia, we're treating the COVID-19, the influenza, pancreatitis, anything that's causing the ARDS, it buys us time, okay? But the interesting thing is that in the last 50 years, we recognize that even though you need mechanical ventilation in these patients, it itself can cause injury to the fragile lung. The lung is already damaged, it's all inflamed and swollen, and then you add this artificial hit on top, and it actually can worsen lung injury in these patients, okay? And this is, of course, the concept of ventilator-induced lung injury. I would say one of the biggest advances in our understanding of ARDS in the last 50 years is a really nice review article in the New England Journal of Medicine from Art Slutsky, our former division director in Toronto, and Marco Ranieri, who's now in Bologna, but really showing that when you have the lung that's injured, depending on how you set the ventilator, you can actually make things worse rather than better. And the idea here is that you could see at the top, and that's a rat lung, okay, that's just been isolated. You could see that whether you're ventilating the patient at very low lung volumes, so the whole lung isn't expanded, you can see all those patchy areas of collapse or atelectasis. And if you ventilate the lung with too high a pressure, you can get overdistension, like a balloon that's about to pop, right? Both of these ends of the spectrum can lead to further lung injury, and the lung is very smart. What it does is it translates that mechanical stress, you can see at the bottom, into a biological stress. Right? So underinflation, overinflation results in this upregulation, transcription, and expression of all these pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1, TGF-beta, IL-6, and all these things leak out of the lung because the lung has been injured. We just talked about it. It's edematous. There's non-cardiogenic pulmonary edema. It leaks out of the lung into the systemic circulation where it can float away to other organs like your kidneys, your heart, your brain, and cause distant organ failure, and that's how patients die. 90% of ARDS patients die of multi-organ failure and sepsis. Only 10% die of refractory hypoxemia. So even though you show up with a lung problem, actually the biggest issue is multi-organ failure, and a big part of that, we think, is the syndrome of ventilator-induced lung injury, because if you set the ventilator poorly, you can actually make the injury worse, and you can actually make organ failure worse as well. So there's the whole idea then, it's that we actually want to figure out how we can do less harm in these patients while we're providing the adequate support and trying to get our patients to recovery. And again, this overarching mantra in critical care, and I would say in medicine in general, that less is more, okay? It's probably the biggest thing that we discovered in the last 50 years. So quickly, I want to tell you a little bit about what the evidence tells us about the management of ARDS today, and then finish my talk with some ideas of where we're going in the future. And if there's one message that you leave today's talk with, is really that in the 50 years of research on ARDS is really this landmark trial that tells us that, again, this idea that how we ventilate the lung is important. And if we just pay a little bit of attention to how we set the dials on the ventilator, we can actually have a huge impact on mortality in these patients. And of course, this is the landmark ARDS network trial from the United States, published in 2000, called the ARMA study, where they looked at this idea of lung protective ventilation, right? So that this idea that we know the lung is already injured, we know if we set the ventilator poorly to either underinflate or overinflate the lungs, too much or too little volume, too much or too little pressure can cause a problem. So this was the idea to compare what was happening at the time ventilating patients with about 12 mils per kilo predicted body weight, which was the standard sort of anesthesia type method of ventilating patients in the operating room, which was translated to the ICU, versus taking an approach where we minimized tidal volume, minimized airway pressure, so we protected the lungs. So you just did enough. You didn't have to ventilate to a normal blood gas. You didn't have to make things normal. You just wanted to do enough to get the patient by. And that was ventilating patients with 6 mils per kilo predicted body weight and a plateau pressure of less than 30 in terms of airway pressure. Predicted body weight is key in this, okay? So from mammals as small as the kangaroo rat to as large as the blue whale, size, height, is how we measure lung size, right? And not your actual body weight. If we all gained 50 kilos of weight in this room right now, our lung size wouldn't change at all, right? So the lung size is indexed to height, and height sort of gives you a measure of predicted body weight. And so the idea is what to index breath size or tidal volume to height. And what they found here was they set out to randomize 1,000 patients to this lung protective strategy of low volume, low pressure versus what was happening usually in ICUs around the United States. And they stopped the trial early after 861 patients were randomized, and there was a 9% absolute risk difference in favor of the lung protective ventilation group. I challenge you to think of an intervention in medicine that has such a huge impact on absolute mortality. There probably isn't any, okay? And the sobering thought again is that this is not a treatment for ARDS, right? This just tells us that if we pay attention to how we set the ventilator, we'll cause less harm in our patients while they're supporting them for their pneumonia, pancreatitis, massive transfusion, trauma, and that sort of thing to get them better. So how we set the ventilator is very important. So that's really the cornerstone of management in these patients. And again, unfortunately, despite many decades of research, this is basically what we've got. Along the way, we've developed a few other methods that, again, enhance lung protection. Another major advance was this idea of prone positioning, an idea first pioneered by Luciano Gannoni, a giant in our field, as you know, who unfortunately passed away earlier this year in April. But even over 30 years of Luciano developing the idea that putting the patient in the prone position actually had a huge number of benefits. Ventilating a patient in the prone position, pound for pound, it's way more lung protective than ventilating them in the supine position. Okay, and he made observations of this using quantitative CT scanning back in the 70s and 80s. Okay, and then finally culminated in this clinical trial called PROSIVA, led by Claude Guérin and colleagues in France, showing that indeed there was a gigantic, like 50% relative risk reduction in mortality by ventilating moderate or severe ARDS patients in the prone position for up to 16 to 18 hours a day. Okay, and I don't know about here in Sri Lanka, but during COVID, this was a major important maneuver that we did in our ICU on almost every COVID patient. In fact, we convened a team of people who just their whole job was to prone and unprone patients every day in my ICU for COVID. But again, led to a very dramatic mortality benefit in patients. And again, the idea here, just briefly, is that this is a lung protection maneuver. So we're not looking when we flip the patient onto their stomach to see that the oxygenation improves, the plateau pressure goes down, the lung mechanics improve. That doesn't always happen. But as long as they don't die, okay, when you prone them, that over 3 or 4 days, what the trial showed is that this protected the lungs more, and even patients who had worse oxygenation after proning had a mortality benefit from this maneuver, okay? So it's not about fixing physiology, it's about fixing lung injury. Okay, that's really the key thing. Those are the two strong recommendations from our evidence-based guidelines. There's a bunch of things in the middle that, in the right circumstances, we do want to consider. One is the use of higher positive end expiratory pressure, or PEEP, something that's been described since ARDS was first coined in 1967, that they found this very interesting button on the ventilator called the retard button, that they could actually stop exhalation, and that led to this positive end expiratory pressure in these patients, and it seemed to be beneficial, seemed to improve oxygenation in these patients, okay? And for 50 years, we've been arguing about what the best PEEP is. I think what's clear, and this is work from one of our former graduate students, Jose Diante in Toronto, and my colleague Ewan Gallagher, did a network meta-analysis of studies that showed that higher levels of PEEP, the sicker the lungs are, the more stiff they are, using higher levels of positive end expiratory pressure, or PEEP, seems to be beneficial. And again, this network meta-analysis showed, is a Bayesian network meta-analysis, showed there's a 99% chance that it's going to be beneficial. Okay, so in the right patients who aren't compromised from a hemodynamic standpoint from the use of higher PEEP, we recommend the use of higher PEEP in patients with sicker lungs. The challenge, of course, is that you'll probably ask me, okay, fine, I'm convinced, let's use higher PEEP. How do we do that? What is higher PEEP? Do I roll the dice, and if it comes out 11, I give 11, or that sort of thing? That's probably just as effective as any other method. But the idea is that we don't really know. That's really the challenge. And so there's a lot of proponents in the field, and it's been studied many times, that this idea that whether we use a PEEP FiO2 table, so the higher the FiO2 that you're on, the more PEEP you employ, because again, it's a signal that the lungs are stiffer, sicker, more injured, or these other sort of more personalized methods of using the individual physiology, looking at their airway pressure, looking at their stress index, looking at the esophageal pressure to set PEEP. Maybe those are better ways to customize PEEP setting in these patients. The challenge, of course, is that we have this nice study from Davide Chiumello from Italy that showed that on the right, the last three, express, stress index, and esophageal pressure, these are all sort of fancy ways of looking at the individual's physiology and trying to set PEEP according to their physiology. But when you compare that to LOVES, which is a Canadian study of higher PEEP, that used a very standard PEEP FiO2 table, actually the table was the only reliable method that put higher PEEP in sicker patients. The other methods, some of them actually put lower PEEP in sicker patients, which again was what we just said was not what we wanted to do. So at the end of the day, we still don't know the best way of setting PEEP, but what I would suggest to you is that because simple things are good, the PEEP FiO2 table is a very cheap and easy way to start in almost any ICU. And then if that doesn't sort of work out the way that you think, then moving to some of these more sophisticated methods might make a lot more sense, okay? So keep things simple, start with something that's easy, and then move to something more complex if needed. We have some ideas that early neuromuscular blockade to relax the muscles, again, prevent large breathing efforts might also be effective. We have this study again from the ARDS network in the United States called the ROSE study that studied 48 hours of continuous neuromuscular blockade with cisatracurium as compared to none in these patients. And what you see here, the Kaplan-Meier curves, is that they essentially overlap. There was no significant mortality benefit in this study. But the important caveat to this study was the fact that about 30% of patients who were screened for the study were excluded from inclusion because clinicians already gave them paralysis because they thought it would be useful. Okay, so there's still a lot of controversy about the utility of neuromuscular blockade, but when you put all the evidence together in a meta-analysis, it actually suggests there's a signal for benefit in this population. So in the right patients, again, who are failing more conventional sedation, they're failing to synchronize with a ventilator, they seem to be making very large breathing efforts, a trial of neuromuscular blockade might be very useful, and that's what the guidelines would suggest. There remains a lot of controversy about the use of steroids in ARDS, but what I might suggest to you is that there's a growing amount of evidence to suggest that it's useful in many settings. Again, COVID was an important example of a very homogeneous form of ARDS, where we now have many studies like recovery that show the benefits of dexamethasone in recovery. We have a study from Europe led by Jesus Villar, the DexARD study that also showed a benefit. And again, now studies in severe pneumonia, Cape Cod recently published in the New England Journal suggesting a benefit. So overall, again, here's a meta-analysis that shows a significant benefit for the use of steroids in these patients. But I would say a lot of clinicians still have equipoise about this issue. So importantly, there's now a very large randomized controlled trial in the UK called GUARDS, being led by Danny McCauley and Manu Shankar Hari, as well as a very large study being led out of Canada by my colleagues Brem Rochberg and Lorenzo Del Sorbo that will enroll nearly 4,000 patients with ARDS to look at the role of corticosteroids. So hopefully in a few years, we'll have some better answers. And then again, of course, in the COVID-19 pandemic, there was the second explosion after H1N1 and the use of extracorporeal support, or ECMO, for the very severe group of patients that were here. This is a very nice review led by my colleague, Lavina Munshi in Toronto, showing the different ways that we can use veno-venous ECMO, which is the primary form of support for these patients. And again, we have evidence now that suggests that the use of ECMO in patients with very severe ARDS leads likely to a mortality benefit. On the left is the Eolia trial, led by Alain Combe and colleagues in Paris, showing an 11% absolute risk difference in favor of ECMO in patients with severe ARDS. Didn't quite achieve statistical significance. We stopped the trial early for futility to show a statistical signal. But on the right, when you look at all the secondary analyses and the amalgamation of the data, each of the Bayesian reanalysis, study level meta-analysis, individual patient data meta-analysis, and one of maybe 6 network meta-analyses all show a significant benefit for ECMO in these patients, okay? And even in COVID, where we couldn't conduct a randomized controlled trial, one of my graduate students, Martin Erner, we used global data from the COVID-19 Critical Care Consortium. We emulated, okay, so we sort of used the data to emulate a clinical trial, and found a very similar 7% absolute risk difference even amongst COVID patients. So all the data around ECMO being very consistent to show that it now has a benefit in the most severe patients. Just a quick word about what we shouldn't do. So we tried lots of things in ARDS. So here are just some things like inhaled pulmonary vasodilators, using very aggressive lung recruitment maneuvers, high frequency oscillation, and again, using a lower flow CO2 removal devices. These have been recently studied in many large randomized control trials. None of them showed an improvement in mortality. Some in fact showed a signal towards harm. So these are things that the guidelines actually suggest we don't do routinely in patients with ARDS. And then in the last few minutes, I want to finish about where we go next, okay? So in terms of what do we do now, I hope that I've shown you in a quick whirlwind tour of the evidence of what makes up our clinical practice guidelines on the use of mechanical ventilation and its adjunctive strategies in patients with ARDS. So we have an international guideline that we published in 2017 that was together with the American Thoracic Society, the European Society of Intensive Care Medicine, and the Society of Critical Care Medicine. We just updated that recently last year, led by my colleagues Nida Kadir and Serena Sahithia, describing what we just discussed as the evidence-based strategies. And again, if there's one thing that you leave with today, the message is low tidal volume ventilation, low tidal volume ventilation, low tidal volume ventilation, okay, for all patients. And again, the idea is to move through that system in a relatively stepwise fashion, okay? You don't want to start with ECMO for everybody, the most invasive, costly, and aggressive intervention. We start with low tidal volume ventilation. You might start with some sedation, paralysis, higher PEEP, proning, this sort of thing. We work through the gamut of these phases, and ultimately in patients who are refractory, we might end up at something very aggressive like VV ECMO. And again, there's no specific time. A common question is like, well, how do you know how much time to give to any of these maneuvers? Kind of depends on the patient response, right? A patient who's crashing and burning and becoming very hypoxemic within hours, again, we saw lots of this in COVID, maybe they get onto ECMO in 6 hours from the emergency department, right? Versus some patients will progress very slowly over days, right? They spend a few days prone, they spend a few days paralyzed, and then things are actually working and they're getting better, which is great, or they're not getting better and maybe those patients progress to ECMO, okay? So it really depends on the patient response. We try to move from sort of the more least aggressive, widely available, less risky interventions first, and then kind of work our way down towards something aggressive and invasive like ECMO as patients fail some of those strategies. We're very interested in new targets for lung protection that we're investigating further. Something that's sort of very hot in the ICU world is this idea of driving pressure. And again, it's the idea that rather than looking at tidal volume or plateau pressure, maybe this parameter of driving pressure, which you see on the right, is indexing tidal volume, not to predicted body weight, but to compliance of the respiratory system. And that really maybe more scales the tidal volume to the part of the lung that's actually still receiving ventilation. Something, again, Luciano Gattinoni called the baby lung, right? So that if the lung is very injured, there's only a little bit of lung available for gas exchange and is relatively normal. And maybe we want to scale the breath size to that lung rather than the whole lung in the patient, and that might be better. And this study from Marcelo Amato in the New England Journal a few years ago actually showed that driving pressure was the most strongly linked parameter to mortality, better than tidal volume and better than plateau pressure. So a lot of interest in driving pressure as the new kid on the block for how we should be designing ventilator strategies. We've looked in our data in Toronto, this is work by Martin Erna again, showing that yes, higher driving pressure leads to higher mortality. Interestingly, higher driving pressure seems to be important to the whole duration of mechanical ventilation, and we saw some effect modification in that driving pressure seems to be most important in the patient with the sickest lungs. And again, while we're waiting for a clinical trial, we again emulated a randomized trial where we showed, yes, even when you're providing lung protective ventilation, if you also reduce driving pressure, that led to a mortality benefit of about nearly 2%. So there seems to be some additional benefit from looking at driving pressure on top of tidal volume. The good news is that we've launched an international randomized control trial called the DRIVE study. It's being led by Ewan Gallagher, Neil Ferguson, and Serena Sahithia at Johns Hopkins. On our international platform focused on hypoxemic respiratory failure in Canada called Practical. So we're enrolling up to 4,000 patients around the world to answer the question of whether a driving pressure limited strategy is better than what we're doing now with lung protective ventilation. We've just randomized our 325th patient yesterday morning, so things are slowly moving along. We're hoping to have over 100 centers around the world enrolling patients in this study, so hopefully in a few years we'll have some more answers for you on this very important question. Maybe rather than focusing on a single parameter, you put a whole bunch of parameters together and come up with something that's more holistic about lung injury. And again, this is another pioneering idea by Luciano Gattinoni, which was to convert the equation of motion of the respiratory system into variables you could see on the ventilator and looking at mechanical power. So it's not just the pressure, it's not just the volume, it's not just the stretch, but every time the ventilator delivers a breath to the injured lung, it delivers energy, and that energy has to be dissipated by the matrix and all that sort of thing of the lung, and the more energy the lung has to dissipate, the more injured it'll be, okay? And the more you do it per second or per minute, the worse it is for the lung. So this is the idea that you could divide it into the component that distends the lung, moves the gas, and keeps it open. Each of these contribute to the power. You can calculate it very simply, again, with ventilator variables that are there. And maybe this is a way to look at all kinds of things that might contribute to lung injury. So we can target not just volume, not just pressure, but a whole bunch of things together. And maybe that'll be the holy grail for this. Another one of my graduate students looked at this in our data. Yes, it looks like the higher the mechanical power in these patients, the higher the injury or the higher the mortality. So again, perhaps a strategy looking at reducing mechanical power could be the next sort of thing to go. As I mentioned to you, every few years we get together and come up with a new definition of ARDS. So there is now a proposal for the new global definition of ARDS that's come out just last year that also helps to apply to low middle income settings and includes intubated and non-intubated ARDS patients. So you can have a variety of different scenarios where you can have patients with just on high flow nasal oxygen or these sorts of things or non-invasive ventilation that will be counted at ARDS. We need this to be validated prospectively to see how it goes. And there are some places around the world that are working on that. Just going to finish quickly to say, and perhaps the final thing is to think about this idea of personalized medicine is the idea, again, because we have syndromes and not diseases in critical care, we have very heterogeneous populations. And maybe there's some groups within there that could do better than others. And again, it's this idea of heterogeneity of treatment effect where we could look at subgroups that might be better than others. So I'm just going to finish with that. Sorry for the quick rush. ARDS is a common and life-threatening form of respiratory failure. Management, unfortunately, is supportive at the moment, and mechanical ventilation is the cornerstone of that. Low tidal volume ventilation is really the key. We have some other things that we talked about that could be used as adjuncts, and hopefully I've shown you that there's more data coming in the future. So with that, I'm going to finish, and thank you very much.
Thank you, Professor Eddy. We would like you to join us in the head table if you want to come up back, please. Thank you.
Now I would like to invite the next speaker. It's an absolute pleasure to invite my colleague, Dr. Dilshan Priyankara, who is a consultant intensivist at Medical Intensive Care Unit of NHSL. And he's the founder president of Ceylon College of Critical Care Specialists. And his academic and clinical contributions focus on advancing critical care medicine in Sri Lanka through research, training, and leadership. He's going to talk to us on acute kidney injury and when to start renal replacement therapy. Over to you, Dilshan.
Thank you, Waruni. Good morning to all of you. It's a pleasure to be here in this prestigious conference. And I've been given a task to talk on renal replacement therapy, when to start. So it's very similar to all the patients in the intensive care units, like when to intubate, like when to start certain things. It's still a dilemma in most of the aspects. So I'll go through a case. So you get a patient who's a 40-year-old man admitted with severe epigastric pain with vomiting. On admission, he's spiking temperature and he's tachycardic, he's hypotensive and tachypneic, and his lipase and amylase is high. And he has a raised WBC count, and ultrasound abdomen shows a markedly inflamed pancreas. So it's not that uncommon for you to get these sort of patients. So he was resuscitated with 10 liters of crystalloids. These pancreatitis patients require a large amount of fluids, over 12 hours, and blood pressure seems to be okay with a degree of noradrenaline support, but his urine output is dropped and it's around 80 cc since admission. Sodium is 145, potassium is around 4.9, chlorides it's 110, and creatinine has jumped up to 2.1. He is acidic with the raised lactate, and he requires oxygen to maintain his saturation. And the chest X-ray shows a picture of the ARDS. So the case is obvious that the patient has acute severe pancreatitis with multi-organ involvement. So the question is, does he need renal replacement therapy now? So if I ask you to hands up, I hope you still be in a dilemma whether to start the renal replacement therapy or not. So if not, when would you consider starting? That's also a question. And if yes, what would be your target endpoints? So those are the questions that you should, if you're treating this patient at the bedside, those are the questions that should be going through your mind. So when we look at what the guidelines is, the KDIGO guidelines. So what they say, initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist. So it's pretty obvious if you have a patient with a profound hyperkalemia, profound severe metabolic acidosis with fluid overload, yes, those are definite indications that you might go ahead with renal replacement therapy. But there's another statement stating, consider the broader clinical context, the presence of conditions that can be modified with RRT, like something like a fluid balance, and trends of laboratory tests rather than a single blood urine nitrogen creatinine threshold alone. So when making the decision to start RRT, both are not graded, but this tells you that beyond your conventional indication, there's something else that we have to think of, whether you need to start renal replacement therapy in these patients. So timing, what is early? So the early and late came from the trials. So the definitions that they are given, the conventional or the late, when there are life-threatening indications like acute hyperkalemia, severe acidemia, refractory fluid overload, or uremia. And they considered early at a stage of AKI, the KDIGO 2 or 3, and prior to absolute indications. So we have different modes of renal replacement therapy. So in the spectrum, we have continuous renal replacement therapy and prolonged intermittent renal replacement therapy, intermittent hemodialysis, and the peritoneal dialysis. So there are various modalities that you can select from if you want to start a patient on renal replacement therapy. So how do you decide? So CRRT, if you take CRRT, it's a very slow process. This is preferred in patients with cardiovascular or hemodynamic instability, patients with acute liver failure, and patients who need a fine control of volume or fluid balance. The CRRT would be the best choice. Or patients with significant cerebral edema, because if you give a rapid dialysis, there will be a water and sodium shift that may worsen the cerebral edema. On the other hand, if your patient is profoundly acidic and the patient is severely hyperkalemic, and certain intoxications, and patients where you can't give anticoagulation, especially with CRRT, you may consider intermittent hemodialysis or prolonged intermittent renal replacement therapy, because CRRT is a very slow process, where the dialysis rates are faster in these modalities compared to CRRT. So your decision of whether to go for which mode will depend on the patient's clinical characteristics. So what does the evidence says on initiation of CRRT? So there have been trials looked at this entity. So I have listed out the important randomized control trials which looked at whether early versus late renal replacement therapy on the mortality. So starting from Elaine in 2016, Akiki, Ideal ICU, Start AKI, and the last one was the Akiki 2. So in Elaine, so it was an early versus late initiation of RRT in critically ill patients. Though all those studies were done in patients who are critically ill with an AKI. So this was a single center study, and it was done in an adult ICU, which was mainly a surgical, and patients who are on pressors with a SOFA score of 2 or refractory fluid overload. And the patients, they started at the KDIGO stage 2 with a small number of patients. So what did they find? So early RRT was within 8 hours, and a late RRT was within 12 hours after stage 3 AKI, or if there are life-threatening emergencies to start. So what they found that if you start the patients early, you might find a mortality benefit in these patients. So this was a significant finding. So this was published in 2016. At the same year, apart from that, what they found, the duration of the RRT was late in the early arm, and the length of hospital stay was less. Duration of mechanical ventilation was also less. So it showed a lot of benefit, not only mortality, in patients who have acute kidney injury at the stage 2. If you start early, you might get these benefits. But at the same year, there was another randomized controlled trial, the ETIKI trial, which was a multi-center trial, which was basically based in a medical ICU setup. And they started the inclusion criteria was a KDIGO stage 3 compared to KDIGO stage 2 in LA. So they have more number of patients compared to LA. So the early renal replacement therapy was within 6 hours. The late renal replacement therapy, so they waited, the patient had oliguria or anuria for more than 72 hours, or if the patient develops life-threatening emergency to start. So what did they find? So they found there's no mortality benefit in early versus late groups. But so everyone in early stage got renal replacement therapy. Almost like 90% of patients got renal replacement therapy. But only 50% of patients in the late arm needed renal replacement therapy. So what happened to the other 50%? So the 50% might have had spontaneous renal recovery, or they died. So that gives a signal, can we wait? So these two trials who came in the same year showed contradicting results. Then this ideal ICU trial came, the initiation of dialysis early versus delayed in the ICU. This was again a multi-center trial, and this was mainly in patients who had sepsis and septic shock. And they also included the patients who had KDIGO stage 3 and a number of close to 500. So early renal replacement started within 12 hours, and late if the AKI persists for more than 48 hours or life-threatening emergency to start. But they had to stop this trial because the further enrollment is unlikely to make a difference at that time, as they thought that the longer the delay would be unethical and unsafe for the patients who actually needed the renal replacement therapy. Actually, the trial was deemed futile, not the renal disease. So what they found in the ideal ICU trial, again, there was no difference in the mortality among patients who had early versus late. So again, we are going back. Okay, can we still wait? Can we still wait and allow renal replacement therapy to start late? So then this was one of the largest trials, Start AKI, timing of initiation of renal replacement therapy in acute kidney injury, which was a multi-center trial done over 15 countries. And they included both medical and surgical patients, the KDIGO stage at the 2 or 3, with a large, close to 3,000 patients. So early, they started within 12 hours. Our standard renal replacement therapy, conventional indications beyond or acute kidney injury persisted for more than 72 hours. So delayed arm waited at least 72 hours. So what did they find? Again, they did not find any survival benefit whether you start early or late in this cohort of patients. So if you go through all these trials, So all these trials were done in critically ill patients with AKI, as I said. So LAN was a single-centered study with small number of patients, and that was the only trial that showed that the early is better than being late. So, but it was mainly, they had mainly had surgical patients compared to other trials. We had combination of patients, and ideal ICU basically had patients with septic shock. So the staging, so they, some of the trials started late, and especially Elaine's study started early of the acute kidney injury stage. So in Elaine, 91% of patients in the delayed arm receive renal replacement therapy compared to others. And the other thing is, in the Elaine study, they only used the CRRT, whereas other studies used combination therapies like intermittent hemodialysis or prolonged intermittent renal replacement therapy. So then the same study group, which did AKIKI 1, went on to see the AKIKI 2 trial, which came up in 2021. So at that point, what they had, there was one study showing early is better, but research studies saying you can still delay. So what this group, the study, looked at how far you can wait. So this was done in adult ICU, patients who are on pressors or mechanical ventilation at the KDIGO stage of 3, and who oliguria more than 72 hours or blood urea more than 110 milligrams per deciliter. So delayed renal replacement therapy within 12 hours, so more delayed. So they delayed more when there's a mandatory indication or blood urea more than 140 milligrams per deciliter. So the question is that whether delaying, or how long you can delay the initiation of renal replacement therapy. In their primary endpoints, they didn't look at the mortality. Their primary endpoints were renal replacement free days and mechanical ventilation free days, hospital stay, and renal replacement dependency among these patients. But when they analyzed further, they have found that the patients who had more delayed renal replacement therapy, there's an increased number of patients who died compared to the group who had delayed renal replacement therapy. So what it says, that there might be a certain limit that you can't delay more. So looking at all these trials, what I said, at the moment, early or late, still a big question. The other things that they looked at, when you start early, the complications. So renal replacement therapy is not just a simple procedure. So you get many complications, which includes catheter-related bloodstream infections, which was higher in AKIKI study, where you have started early. And patients in the Start AKI study, patients had high renal dependency, and also patients who had other side effects like hypotension. So looking at all the results, whether you're going to start early or preemptively, or whether you're going to delay it, or you're going to more delay it. So AKIKI 1 and the ideal ICU, Start ICU, and did not show mortality benefit in early renal replacement therapy in KDIGO stage 2 or 3. Maybe possible benefit in surgical patients according to the Elaine trial, but still there are factors that, like the side effects of or adverse effects, which you might have to counteract. And early renal replacement therapy, as I said, had high risk of infection, the risk of renal replacement therapy dependence, incidence of hypophosphatemia and hypotension. And very delayed renal replacement therapy may have worse outcomes. So we are in between. So this was a pilot study. It's called the Furosemide challenge stress or challenge test. It was not powered enough for mortality. So what they did, in the patients who are critically ill with an AKI, who had adequate volume resuscitation, who've been oliguria, given a trial of furosemide. So 1 milligram per kg if the patient is naive for furosemide, or 1.5 milligram per kg if the patient is already exposed to furosemide. And they looked at the urine output in 2 hours. If they produced 200 ml, they thought to be furosemide stress test is responsive, and if not, they are not responsive. So they looked at the patients who are not responsive going into early versus late renal replacement therapy, but there was no difference again. But the important thing is the patients who had responded to furosemide, only 6 patients received renal replacement therapy. So can you avoid renal replacement therapy who are responsive to furosemide, who are adequately volume resuscitated? So now we have a patient whose creatinine is the marker that we go by, going up with the time. And if I ask you, where would this patient head from here, it'd be very difficult to answer. So patient might patient might just spontaneously recover, or patient might get worse and die, and patient might be just static. So the questions that the clinicians were asking, the patient selection on demand versus capacity. So the demand is basically the disease burden, maybe a sepsis, maybe pancreatitis, how much burden on the patient by the disease, or absolute load or volume load. So what's the demand on the kidney? And the kidney has a very limited capacity. So if you have a normal kidney with normal demands, you'll be able to manage it. So you are basically fine. But if you have a patient whose demands are higher, but the capacity is less, then you may need to think of a renal replacement therapy where kidney needs some support. So people are looking at this concept where the demand versus capacity, whether you can build sort of a formula depending on the disease burden. For example, even the furosemide challenge test showing the capacity of the kidney to excrete. So some of the things might come up looking at the demand versus capacity. It's not just only those demand versus capacity. There are so many other things if you want to initiate renal replacement therapy to consider. Severity of the illness and the AKI severity and the trend. The trend is very important, not just static measurements. It's a static picture of the patient. You can't just come in the ICU and see, okay, this patient needs renal replacement therapy. You have to monitor the patient and see the trends. Severity of the burden of the electrolyte and acid-base disorder. Fluid balance, very important. There are so many trials looking at the positive fluid balance or fluid overload with worsened renal outcomes. And the necessity for renal replacement therapy, likelihood of early recovery of kidney function. Sometimes you can wait and watch. You think that the patient might recover. And underlying comorbidities, the patient, and associated acute organ dysfunction. And the risk of RRT, starting RRT is a risky procedure. You put vascular catheters, they might bleed, they might get pneumothorax, they might get infections. So there are so many complications associated with these procedures. So to look into that. Other factors like patient and the family. Sometimes we might do renal replacement therapy where a patient didn't want renal replacement therapy. and the overall goals of care, where you are heading with this patient. Like, dialyze forever in the ICU. And the availability, it's very important in our setting, what the availability of the resources that we have, to whom we're going to offer this, and the cost. So those are the other factors that you have to look into, not just on the patient and the evidence. So my final side, so what should we do? You look at the evidence and look at all the factors that around the patient whom you are treating, and basically you individualize, as the previous speaker said, you precision medicine in ARDS. So the precision medicine comes in every aspect of patients who are critically unwell. Thank you.
Thank you, Dilshan. You may join the head table now.
Right, so let me introduce our third speaker of the symposium, Dr. Darshana Hewa Kandamby. Dr. Kandamby completed her undergraduate studies in Faculty of Medicine, University of Colombo. She went on to her postgraduate studies in the field of intensive care and obtained Fellowship of Intensive Care from Hong Kong College of Anesthesiologists and the Fellowship of College of Intensive Care, Australia and New Zealand. She has been in the field of intensive care for the last 20 years. Currently, she is the Chief of Service of the Department of Intensive Care of Princess Margaret Hospital and Yang Chai Hospital, Hong Kong. Dr. Kandamby's field of special interest is extracorporeal membrane oxygenation. The topic that she has chosen for us today is clearing the roadblocks. I invite Dr. Kandamby to take on the next session.
Thank you, Lilanthi, for the introduction. Good morning to you all. Pleasure to be here. So, time crunch, let me get on with it. Clearing the roadblocks. So first, we'll start off with a case presentation. So this lady presented to our hospital in July this year with abdominal distension, and she was admitted to the gynecology ward, and she was found to have ascites, and the ultrasound found a mass above the uterus. So her CA125 was elevated. She got a paracentesis done and fluid sent for cytology, and she was discharged. But 1 week later, she presents again with chest pain, shortness of breath, and abdominal distension. So this time also she had a paracentesis done. And however, 2 days later, she goes into respiratory distress, needs oxygen, desaturates down to 90%. She was tachycardic, and the ECG shows sinus tachycardia. D-dimer was elevated, and the troponin I, which was normal at presentation, has gone up. So the diagnosis is screaming at you, isn't it? She got a CTPA done, and surprise, there's bilateral pulmonary embolism and with features of right heart strain. So the road, clearing the roadblocks, the road, what I'm referring to is the pulmonary arterial circulation, and the block is the pulmonary embolism. So let's see how we are going to clear this roadblock. First, we need to, before we start therapy, we need to find her risk level. So European Society of Cardiology and American Heart Association has given up risk stratification guidelines. Two risk stratification levels, methods, but they overlap very nicely. So according to the American Heart Association, the patients are stratified into massive, submassive, and low risk. The European Society of Cardiology stratifies as high risk, intermediate risk, and low risk. For the high risk or massive group, The patients are hemodynamically unstable, and their mortality rate at 30 days is up to 30% high. So intermediate or submassive group, their hemodynamics is stable, but they have right ventricular dysfunction, and they have a mortality rate about 3 to 15%. For the low risk category, it's not the critically ill patients. They are stable and no RV dysfunction and with a low mortality rate. According to the ESC, they further stratify this intermediate group of patients into high and intermediate low groups. So for the intermediate high groups, they also looked at the pulmonary embolism severity index, PACE score, or SPACE, simplified PACE score, RV dysfunction, and also the cardiac troponins. So for our patient, she has elevated troponins. The CT found right ventricular dysfunction, strain pattern, and for the SPACE score, when I key in, she gets a +1. So she's in the high intermediate risk group of patients. So according to the ESC guidelines, what is the treatment? Recommended treatment is anticoagulation with rescue thrombolytics as a rescue therapy, and also the surgical embolectomy and catheter-directed treatment as a rescue therapy. So in the next few slides, next part of the presentation, I actually want to focus a little bit on the catheter-directed treatment for pulmonary embolism. So this patient was started on low molecular weight heparin, and she was admitted to the ICU. This was on a Saturday night, and the echo found RV strain pattern. So who should go for catheter-directed thrombectomy? Certainly not the low-risk groups. High-risk patients, yes. Probably they benefit from this together with ECMO support. And intermediate high-risk group who are having a bulky proximal clot burden and severe symptoms may also benefit. So those two categories, patients in those two categories may benefit. So she was stable over Saturday night, and on Sunday morning she went ahead with a catheter-directed thrombectomy. She went for the procedure and she got the catheter inserted, which is a small catheter, French 4 catheter, up to the pulmonary trunk. But at that point, she deteriorated. She became hemodynamically unstable. So she was brought, so the procedure is abandoned. She's brought back to the ICU and put on ECMO. So while we were cannulating her, she arrested. And but managed to complete the circuit with a downtime of 8 minutes. So after that, she was stabilized, and she woke up to obey commands as well. So next day, she was stable enough to go to the radiology suite, and this time they put in a bit bigger sheath, 12 French sheath. And this time they did vacuum aspiration thrombectomy. So on both sides, but only the left side was successful, but the pulmonary arterial pressure did come down. So what they did was they put in another smaller catheter to the right side and positioned at the right pulmonary artery, and through this thrombolytic infusion was started. So this form of treatment is called catheter-directed lytics, or CDL. Back to ICU, and next day, so this is Tuesday, she goes to have a look, and angiogram finds that the right embolus is still there. It has not cleared with the thrombolytics. So she undergoes the third session of catheter-directed therapy. So this time she got a large a large catheter in. This picture shows what's called the flow retriever catheter. So the one on the left, B, is called the retriever catheter, which is, in this patient, they put a 24 French catheter in after the pulmonary circulation, and they tried aspiration thrombectomy as well, but still it's not budging. So then they put in what is shown in the picture A. It's called the flow retriever with the discs over a guide wire, and this disc will engage the clot and pull back the clot, and then aspiration thrombectomy can be done. So this time it was successful, and they managed to suck out hard clots. So this is a large bore thrombectomy procedure. So let's just have a look at the catheter-based approaches for pulmonary embolism. Largely speaking, there are two methods. One is the catheter-directed lytics, and the other one is the catheter-based thrombectomy. So the patient that I selected to show you today, she got all the works. She got the CDL, and she also got the catheter-based thrombectomy. So CDL involves putting in a small catheter directly to the pulmonary circulation, and through that, lytics are given over 6 to 12 hours. So the advantages are that you only need to give much lower thrombolytic dose, while for systemic thrombolytics, you give, say, 100 milligrams of alteplase. Here, you give 1/4 of the dose or less. And the other thing is that since you put the catheter right after the pulmonary artery, it gets to the location properly. Whereas when you give systemic thrombolytics, you don't know whether it will really get to that point because that area is blocked. Then another variant of this is ultrasound-assisted thrombolytics. You need a special catheter with several lumens. One lumen will house ultrasound filament, which will emit high frequency, low energy ultrasound waves, and that will break up the clot a little bit. So effectively increasing the surface area where the lytics can work. And through another port, the lytics are infused. So the commonly quoted system for this is ECOS. Then how about the catheter-based thrombectomy? Again, different techniques are there. One could put a guide wire or balloon through a catheter to cause maceration of the thrombus. Or another method is called the rheolytic thrombectomy, where high-speed saline jets are created at the distal part of the catheter, creating a vacuum, so that can suction out the thrombus. Then the last one is large or small bore embolectomy, which this patient got last, the one that I explained to you before. So evidence. The last decade, there has been a lot of studies done on this, and at the moment also lots of studies are being done and are being published. So let's have a quick look at some of the studies that has been published. Ultima study, it's a randomized controlled trial which was published in 2014. So basically it's looking at the effect of ultrasound-assisted thrombolytics plus heparin versus heparin in the intermediate risk group of patients with pulmonary embolism. And what they found was that in the ultrasound-assisted thrombolytic group, the RV-LV ratio reduction was much more significant than the heparin alone group. In 2018, Optilize PE trial was published. This is a randomized control trial. The objective of this study is to look at the optimal dose of thrombolytics that can be given through the catheter-directed lytics. So they basically had 4 groups of patients. The lowest group dose was 4 milligram per lung. So if both sides are blocked, then the patient will get 8 milligrams of alteplase. So 4 milligrams over 2 hours, 4 milligrams over 4 hours, 6 milligrams and 12 milligrams. So 4 groups. And then the primary endpoint was efficacy endpoint to see the RV-LV ratio reduction. In all 4 groups, the RV-LV ratio was reduced well, but there was no difference between the groups. So actually, you can go down to like very low doses of thrombolytics effectively. Now we look at the thrombectomy groups. So this is a single study just to look at the efficacy of thrombectomy. The device used in this trial is the flow retriever system, what I showed you for this patient. And they also recruited intermediate risk patients. Again, they found that this system would effectively reduce the RV-LV ratio at 48 hours significantly. Very similar study, but using a different manufacturer, indigo aspiration system. Again, they found the study was done on intermediate risk group patients, and they found that RV-LV ratio was reduced significantly at 48 hours. And also the side effects of these, both in these studies, they found that there's minimal risk of death due to the device, minimal major bleeding and other side effects. So can be used safely. Okay, now we come to studies where they compare these different techniques. So this study is the first randomized control trial that is comparing different techniques. And what they compared here is the flow retriever system to other catheter-directed lytic therapy. So the primary endpoint was a hierarchical composite of all-cause mortality, hemorrhage, ICH, bleeding, ICU admission, clinical deterioration, and ICU duration. So what they found was the composite endpoint was significantly lower in the large bore catheter mechanical thrombectomy. And so it's favoring that. But the outcome was mainly because of reduction of clinical deterioration and ICU admission and ICU length of stay. Then lastly, we look at a study that is done on high-risk group. So all the studies that I have showed before were done on patients with intermediate risk pulmonary embolism. This is the only study that is, I'm showing you, that is done on high-risk patients. It's difficult to do RCTs on this group of patients because they are very unstable. So this is a prospective multicenter randomized parallel group observational study where some of the patients got the flow retriever large bore mechanical thrombectomy, and the others got all the other conventional therapies. So most of them got systemic thrombolytics up to 70%, and a large proportion ended up getting heparin. Some got CDL, catheter-directed lytics, and one got surgical embolectomy. So again, the primary endpoint was a composite endpoint of mortality, bailout therapy, and clinical deterioration and major bleeding. So the primary endpoint was much lower in the large bore mechanical, the flow retriever system patients, and as opposed to the conventional treatment. So what does FLAME study show us? It provides evidence to incorporate large bore mechanical thrombectomy into standardized protocols rather than as a rescue therapy. And so current recommendation for high-risk pulmonary embolism is where the percutaneous catheter-directed treatment is for when the systemic thrombolytic has failed or as a rescue therapy. But in fact, in the future, maybe it can be a main treatment as well, together with, same as systemic thrombolytics, provided that you have the facilities. Okay, so next few slides. So this patient also got ECMO. So I just want to touch on the place of ECMO on pulmonary embolism patients. So of course, there's no guidelines on this. But there is this article was published earlier this year in Journal of American Heart Association. It actually discusses various types of mechanical circulatory devices, but mainly discussing the place of ECMO. So this chart shows when a patient presents with pulmonary embolism, if the patient is in shock, you can consider ECMO and then go on to do the definitive treatment and subsequently slowly wean off ECMO. If not, if hemodynamically stable, you can do the definitive therapy. When subsequently the patient deteriorates, again you can consider ECMO. Now this is for hemodynamic support, which is veno-arterial ECMO. They also suggest that if the patient is in severe respiratory failure and difficult to ventilate, you may consider veno-venous ECMO, which is respiratory support. So what we can say right now is that ECMO may be used to stabilize patients as resuscitation ECPR, or bridging to definitive therapy, bridging to recovery, and also maybe VV ECMO. But ECMO is not, it's a high risk procedure, so you really need to choose your patients. You don't want to, my personal opinion is, you don't want to put an intermediate risk patient on ECMO, anticipating that the patient will deteriorate later, because patient might die of complications of ECMO rather than pulmonary embolism itself. So I believe it's the place for ECMO should be for high-risk patients. So this is my hospital pathway that we have been using for the past several years. So when the patient, it's actually a little bit similar to the previous flow chart that I showed you. So it's if the patient presents with high risk or intermediate risk PE, or if the patient develops cardiac arrest, then you can consider ECPR in suitable patients. If not, patient is stable, you can go ahead with other treatment. But if the patient becomes unstable with needing hemodynamic support and end organ failures, then they will consult the ECMO team, which is in the ICU, and we will assess and see whether the patient needs ECMO. And for this, PMH means Princess Margaret Hospital. So this hospital, usually what we are doing now is, if the patient is high risk, needing hemodynamic support, we would put them on ECMO after admitting to ICU, and then go for catheter-directed therapies rather than systemic thrombolytics. So that's what we do. But we also take care of another ICU in another smaller hospital where they don't have catheter-directed therapies immediately. So then they may end up getting systemic thrombolytics. Or else we can go there and put them on ECMO and bring them to this hospital to do the catheter-directed therapies. So yeah, so that. So what happened to our patient? She did very well. She was weaned off ECMO on day 5, and then she was extubated the following day, and on day 7 she was transferred out of ICU. So actually from in the cohort from all the ECMO patients, the pulmonary embolism, ECMO patients with pulmonary embolism, they actually have a good prognosis and good outcome. Most of the time they can be weaned off ECMO and discharged. So this slide, this photo is one of my favorite photos. We took it just after an ECMO cannulation on 31st of December. Let's look at the summary. So catheter-based treatment is more and more commonly used with promising results. And actually now there is more evidence that these kind of treatments can be incorporated as first-line therapy as well. As the guidelines that are currently available are a little bit old, like AHA guidelines are in 2014 and ESC guidelines are in 2018 or 19. So maybe the next guideline will give us some incorporate the new evidence as well. And then VA-ECMO can be considered in high-risk patients as bridging therapy in the appropriate patients. Yeah, thank you.
Thank you, Dr. Darshana, for that wonderful few words. So we would like you to come and join us in the table.
Okay, as all three scheduled talks of this session are completed, now we will be moving on to the discussion. So to initiate and conduct the discussion, now I would like to invite our expert panelists to the stage. Dr. Dilushi Wijayaratne, Senior Lecturer in Medicine and Consultant Nephrologist, Faculty of Medicine, University of Colombo. Dr. Riaz Mowjood, Consultant Respiratory Physician, Navaloka Hospitals, Colombo. Dr. Anushka Mudalige, Consultant Intensivist, North Colombo Teaching Hospital, Ragama. Dr. Rasanee Wanigasuriya, Consultant Intensivist, Colombo South Teaching Hospital, Colombo. Okay, over to the expert panelists to get on with the discussion. Yeah.
Good afternoon to you all. I'd like to ask one question from Professor Eddy regarding ARDS management, actually. What is your experience on steroids, actually? How do you do it? What is a drug and what is a dose and how do you do it?
So, excellent question. I would say our experience probably follows the evidence that on the whole, we see that it's typically beneficial. And I think when you're asking the question of steroids, there's maybe two opportunities to use it. One is in the early phase, which again, the increasing evidence from recovery and COVID, steroids in early ARDS, for instance, in DEXA ARDS that was published in The Lancet. That's typically a dose of dexamethasone from as low as 6 milligrams in COVID situations to 20 milligrams a day in DEXA ARDS. And again, that seems to be beneficial, similarly to Cape Cod, other studies. So our experience is that it's likely beneficial, again, based on the evidence. I would say in our ICU, as I mentioned, we still have equipoise. And so we're actually enrolling patients now who meet the criteria in a very large randomized control trial. So the best way to figure out the answer to your question is to randomize. And so hopefully we'll have an answer from that trial in the coming years. But our hypothesis is that it would be beneficial based on the previous work. And of course, you can give steroids late in ARDS, right? So in this previous idea of giving high-dose steroids, 2 milligrams per kilogram, for up to 2 weeks in late phase or fibrosing ARDS, that in most studies have really not shown much of a benefit. Yeah. So we don't routinely give steroids in that sort of situation.
Sure. So when would you really start it? Like if you have put the patient on the ventilator, when would you consider starting?
Yeah, again, so the studies suggest, so again, at the moment, we don't routinely do it because we're randomizing patients in a study.
Right.
But I think according to the current evidence, yeah, once they meet ARDS criteria, you might start the steroids, say dexamethasone in those patients. But maybe an example to give you is that, for instance, patients who deteriorate on our ward, who are already receiving steroids by the Cape Cod protocol, we wouldn't stop steroids in those patients.
Right.
Yeah.
Okay.
So we're hoping to get an answer on the starting steroids at the onset of ARDS, which I don't think we know for certain, but certainly in patients who now get steroids, which I think is increasing for, say, community-acquired pneumonia, we wouldn't stop those steroids when it comes to ARDS.
Okay, thank you very much. I can just ask one more question. Regarding phenotypes, like what is your experience for ARDS?
So phenotypes, another hot topic, right?
Yes.
The holy grail of personalized medicine. Is there a way for us to look at the patient and see baseline characteristics, their respiratory system compliance, their CRP, their age, and all these things that might predict response to a therapy or not? The idea of phenotypes. So, in ARDS, this has been popularized by Carolyn Calfee at UCSF, looking at hyperinflammatory versus hypo-inflammatory phenotypes. And the very interesting thing there is that it's very clear that you can see differential treatment response based on phenotypes, right? It seems that the hyperinflammatory patients respond better to fluids, higher PEEP, simvastatin, these sorts of things. So this might give us the promise of personalized medicine at the bedside. The challenge, of course, is that right now to do these phenotypes, right, you need to run this whole array of molecular things like measuring IL-1, IL-6, like it's not available at the bedside, right? So right now it's a research test, but don't disagree that they're working on ways to bring this to the bedside through,
Clinical phenotypes, isn't it?
yeah, exactly.
Yeah.
Some clinical classifiers, and then now we have another trial where we're enrolling patients with a point of care test made by a company where we can actually get pretty real-time IL-6 measurements. So we're trying to see in a large platform trial run out of the UK called Panther, whether phenotyping at the bedside and then modulating treatment based on those phenotypes leads to a benefit. So it's coming, but like many things in critical care, I would say we should be humble. We've tried many things in clinical trials that we thought would work, and not only did they not work, but they failed, right? And so the thing here is that we think it's very promising, but we need to test it. And so that's what we're trying to do.
Thank you very much.
Thanks. So I have a couple of questions to ask Dr. Dilshan about managing AKI and RRT. So the first is you very clearly explained in your talk that there's no clear benefit from early initiation of RRT. There may be harm, but there is possibly harm from very delayed initiation of RRT. And then in our context, availability is also an issue. So how do you balance these potential benefits, risks, and availability when you are deciding whom to dialyze and especially offer CRRT to in your ICU setting?
Yeah, I think it's a major challenge for us. Not only now, we see around and more than 2/3 of patients in the ICU will have some degree of acute kidney injury. And if you take the burden of chronic kidney disease in our country, so very likely that we get patients with chronic kidney disease or acute on chronic kidney disease, so who had never been dialyzed earlier and now might end up dialyzing and end up with permanent, needing dialysis for a longer time and even a KT. So it's very important in our setting that we go by the guides or the guidelines, and also looking at the current clinical picture of the patient. And I think in our setting it's very important that we should not give futile treatment in certain situations where we drag on patients, suffering the patient's quality of life. So those are also that we need to, in our setting that we have to, because we don't have the certain things like, end of life care, proper guides as per, people may be reluctant, like, if I don't offer this, would I be in trouble? So those are also things that, when we manage patients, that will come into play. But all in all, if you do the right thing, which will benefit the patient, looking at everything, the cost and everything, so it'd be really important to see your where you're going to head. The other thing is the expertise that you have on renal replacement therapy in your ICU. How trained your ICU staff, how trained is your ICU nurses, or the staff, whether they can handle, not just starting it, how to continue it and troubleshoot it. So those are also very important. I think it's really important, to pass the message across Sri Lanka, how, go about these patients who may need, who may not need, and who still need, but will not be worth of.
Thank you. So perhaps like a bit added on to that same question and your response, you mentioned capacity and demand of the on the kidney when you're deciding on whom to dialyze. So we could assume that patients who are older, who have a bit more multimorbid, like say with heart failure, may physiologically need RRT earlier than those who don't have these issues. Would you consider starting dialysis earlier for patients like that? Or would that not be a factor in your consideration?
It's a very difficult answer actually. It's always depend on the current clinical status of the patients most of the time. But the background physiology plays a big role. How they cope up with, for example, if you have a patient with a congestive cardiac failure, coming with acute decompensated heart failure and acute kidney injury, they may not tolerate the renal replacement therapy. As a patient who had a good heart. So to a certain extent, yes, I would consider, but overall, go by the overall picture and also the trajectory of this patient, where this patient is heading. Sometimes we can avoid the renal replacement therapy and just, maybe with some furosemide challenge test, so we can avoid certain patients who are going, who may not need renal replacement therapy.
Okay, thank you.
Thank you, Dilushi and Dilshan. Can you just...
Yeah, I have a quick question. Actually, 3 parts to Dr. Darshana. So have you stopped using thrombolysis, or depending on the severity, with alteplase and moving more towards catheter-directed? And the second question is, have you seen any major systemic bleedings with the catheter-directed? And if so, do you just stop the infusion? And the third one is, after you complete the catheter-directed, do you have to still put the patient on anticoagulation after that?
Yeah, the first question about the use of lytics or not in our hospital, I would say in Princess Margaret Hospital, the trend in the past few years has been for catheter-directed therapies. So I'm seeing less and less systemic thrombolytics for pulmonary embolism because the facilities are available there. And we have ECMO as well to stabilize the patient. And also if the patient did get, it's not that it's not done. For the urgent reasons, emergent reasons, it may be given. But the trend has been for catheter-directed therapies. Also, if the patient did get thrombolytics for some... Should I stop now? Yeah. Okay, so the other hospital where there is no catheter-directed therapies, we do go for lytics. Then your second question was, yeah, anticoagulation is a must. Yeah, it has to be after the lytics are given at appropriate time. The anticoagulation should be given. And the other thing, the second question was whether there was major bleeding due to lytics, due to catheter-directed lytics. No, I haven't seen that. Yeah.
Could I now please invite our chairpersons to award the certificates and letters of appreciation to the speakers and panelists. Could I now please invite Dr. Yapa Udayakumara to award the certificates